speak on. And next, I invite Dr. Swetha for her talk on diagnostics aiding the diagnosis of PACG.
Good evening. Thank you, Dr. Meena ma'am, for this opportunity. I'll straight away go into my topic, that is diagnostics aiding PACG diagnosis and overview. So, the most important, what we have is a slit, first and foremost, is slit lamp examination, gonioscopy, ultrasound biomicroscopy, anterior segment OCT, and the biometry. So the diagnosis starts from at the level of the optometrist. You can all train your optometrist to see the torchlight examination so that we do not miss any cases. So any case of doubt, they can send directly to you. So you can grade it according to the torchlight examination as grade 1, 2, 3, and 4 as shown. Then we have the Van Harris technique, which is a slit lamp examination. It is also known as a limbal anterior chamber depth measurement, where it is graded based on the anterior chamber depth is compared with the corneal section, and grade 4 is more than or equal to 1, and grade 3 1/4 to half, and grade 2 equal to 1/4, and grade 1 less than 1/4. So grade 1 is one which we can have the occludable angle. The most important test that we have is a gonioscopy. This is still the current gold standard method for detecting the angle closure disease. Especially it has to be done under dark room, the dynamic gonioscopy. So here you can see the real-time image of a gonioscope, an open angle, where you can see the Schwalbe's line, non-pigmented trabecular meshwork, pigmented trabecular meshwork, scleral spur, and the ciliary body band in the right side. So the technique of gonioscopy is really important because you have to make sure that the light doesn't fall onto the pupil, and you constrict the pupil, and that can also always cause a false opening of the angle. So whenever you see the superior and inferior angle, keep the slit height at minimum, and you can increase the width so that you see just that angle. So, and whenever in doubt, you can use the corneal wedge technique. And if when going to the lateral angles, that is nasal and the temporal angles, you have to keep the slit at a minimum width, and you have to increase the height of the slit. The main thing is you should not allow the light to fall on the pupil and allow the false opening of the angle. Next is the corneal wedge technique. Corneal wedge technique is for the detection of the Schwalbe's line. You have the anterior and posterior, light reflects from the anterior and posterior surface of the cornea. It comes and joined together at the Schwalbe's line. So you can identify the Schwalbe's line, and the rest of the angle is easily identified. Then whenever you are not able to see the angle, you can also do the manipulative gonioscopy. What it means is when you're seeing the angle like this, and you can ask the patient to look towards the mirror. Whichever mirror you are examining looks towards it, and you can see that angle is opening. So this is an oppositional one. And always be careful to distinguish between the peripheral anterior synechiae and the iris process. And this is a broad-based peripheral anterior synechiae, and you can see the narrow angle. And also 4-mirror gonioscopy is the one which used for the indentation gonioscopy, but it is little difficult to master. But once you master it, you can just you can see the ostium, trabeculectomy ostium in the superior angle. And this one video is from the iowaglaucoma.org, where you can see that once it is pressed, you can see the angles opening up. So we have to differentiate between the synechial angle closure and the appositional angle closure. But the limitation of gonioscopy is you need a skilled examiner. There can be high inter-observer variability and not able to track progression, and it is highly subjective. And we are not able to see behind the iris. For that, the ultrasound biomicroscopy had come, where there is a high resolution in imaging of ocular structures up to the pars plana region. So principle is similar to B-scan. B-scan uses 10 megahertz, whereas UBM uses 50 megahertz. More the frequency, lesser the penetration, and better is the resolution. We can have qualitative as well as quantitative assessment. There are different scans in UBM. You can have a transverse scan. You can have the longitudinal scan, which has a radial image to the single clock cover, and you can have the axial scan according to the where you keep the mark. I'm not going into detail of the examinations. And probes you can have with the cup, where we can fill it in water and keep it in the patient's eye, or directly you can see the ClearScan device, where you can directly keep it into the patient's anesthetized cornea. So the most important landmark what we have to identify is the scleral spur. So this is an example of an angle closure where you can see the pupillary block and the angles are closed. And this is an example of a plateau iris where you can see the anterior rotation of the ciliary body and the double hum sign of the iris. And even the iris, whatever behind the iris cyst, these can be diagnosed only with the ultrasound biomicroscopy. But limitation is, it is a contact method. We need an experienced skilled person, and repeatability is an issue, and it is time consuming. Then comes the anterior segment OCT, which has so many advancements recently. Initially, it started with the time domain OCT, which had 1300 nanometer light, which had good depth of penetration, but the resolution was not good. Then came the spectral domain OCT, where the resolution was good, but the depth of penetration was less. And now we have the SWEPSOS OCT, which uses 1300 nanometer of light, and it gives us good resolution as well as the depth. So these are few of the examples of time domain and spectral domain OCTs. The OCT is non-contact, and it can minimize the test-induced distortion of angle, and it can be performed by technician, and it has a faster imaging speed and more reliable detection of the key landmark. But it is difficult to identify the anterior synechia and the neovascularization, and it cannot differentiate appositional and synechial angle closure. Here the important landmark what we have to identify is the scleral spur. Scleral spur is a junction between the inner corneal surface and the sclera. So this is a landmark. From the once it is identified, rest of the measurements are taken directly by the machine itself. So this is an anterior image showing the scleral spur, and it can also, the segmentation also has to be confirmed in anterior, and you have various parameters. Among them, the most important is the lens fold. Well, lens fold do have an important mechanism in angle closure. And it's not just the apposition of the iris and the trabeculum Ashok what we are interested in. We have to see the iris thickness also. The increase in the peripheral role of the iris in the periphery is also gives more chance of getting an angle closure. So look for pupillary block, plateau iris configuration, thick peripheral role of iris, and exaggerated lens vault. So some of the differences of UBM and OCT, I'm not going into detail. So mainly we have static factors like lens vault, anterior chamber area and volume, and iris thickness and area, and dynamic factors, changes in iris area in response to the pupillary. And there is something called an ITC index, which is there in the SWEPSOS OCT, where they take all 360-degree of the angle is measured, and it can show us where the iridotrabecular contact is present. The most previous OCTs it was not present, only in the SWEPSOS OCT it is there. So you can see that that blue, whatever is represented here in the lower image is ITC, iridotrabecular contact. So also we can also use a biometry. The importance of biometry is you can see the anterior chamber depth. It is said that if you have an anterior chamber depth which is less than 2.4 millimeter, there is more chance of getting an angle closure there. And provocative tests, we know that we do not use these nowadays, like darkroom prawn positioning and pre and post dilatation. Generally we do not do it. So it's all matters is we all have to see it as a patient together, right from the history taking, and gonioscopy is very important. Even if you feel that the anterior chamber is not that shallow, you have to do the gonioscopy, because that can be an angle closure too. And I thank my mentor, Dr. P. Satyan sir, for helping me out with this. Thank you.
For the excellent talk. You have covered all the investigations, and I think, like you mentioned, the gold standard continues to remain gonioscopy, and it has got a learning curve. One should, even as consultants, I think we keep on improvising on our findings with each time as we